Isaac, can you check if the link is working? It is working. Robert was saying it's not working. Let me just send it again to him.
I have reshared. I've reshared another one.
Hello, everyone. Thank you for joining. We will start shortly. Maybe we take a couple of minutes until other people join. Thank you. Okay. So, Isaac, are you ready? Can we start? I can't hear you.
Hello, Antony? Yes, we can start.
Yes. Okay. Can you be a little bit louder?
Yes, you can start.
Okay, thanks. Hi, everyone. Thanks for joining. I see 72 people so far joining the webinar. We expect more people to join, but for the sake of time, we start. My name is 𝗓𝗂𝗏𝗏 𝗏𝗂𝗏. I am the Nutrition Information System Help Desk within the Global Nutrition Cluster. And I have with me Isaac Macha. He will introduce himself. Isaac, over to you.
Hello, everyone. I'm called Isaac Macha. I work for GNC as part of the rapid response team handling information management. Over to you, Antony.
Thanks, Isaac. Colleagues, please write your name, position, the country you are joining from, and your organization. So far, I see many people posting. For those of you who just joined, please write your details. So this webinar is going to be about 90 minutes. Hopefully, we will finish earlier. It will be mostly a one-way informative session. This is just to highlight the key changes in the revised GNC Nutrition Humanitarian Needs Assessment and Analysis Guideline. For those of you who are familiar with the guideline, it will be an opportunity to know what is new in the guideline. And for those of you who are unfamiliar, new to it, it will also give you an highlight of what the content of the guideline is. And we highly encourage you to access the guideline. I put the link to the guideline and the tools at the chat box. And please take a look and read. You may also scroll through the document while I'm presenting, or also highly encourage you to read afterwards. After all, it is a guideline and a tool to be used in your day-to-day assessment and analysis exercise. So there will be a Q&A session in between sub-sessions, but feel free to post any question you may have while I'm presenting or Isaac is presenting, and we will attend to the questions that you post at the chat box. So with that, I will proceed to the next slide. Isaac, please. So today we'll be covering three main areas. First, I will give you a general overview of the GNC Nutrition Humanitarian Need Analysis Assessment and Analysis Guideline, a bit of background about why the guideline was revised. And for those of you who are familiar with this guideline, the original version was produced in 2020. Afterwards, we made revisions, which is the current version. You may want to know, why the revision was initiated and what was the scope of the revision. And lastly, we will talk about the specific changes made in the guideline, what specific revisions were made. We focus mainly on the structure and terminologies, process workflow, and the content and the methods. So this is not a detailed step-by-step guideline as to how to conduct assessment or analysis. This is just meant to give you a general overview of what is included in the guideline. Next. So for most of you, I do hope you are familiar with this guideline. It constitutes two components: the technical manual, which is a step-by-step process for need analysis. And we have also an accompanying Excel-based analysis tool, which Isaac will be showing us later. And the audience, although primarily is meant for cluster and sector coordination teams, meaning information management officers and cluster or sector coordinators or nutrition emergency specialists, others like partners, national authorities, intercluster coordination mechanisms, and the HCT members, even including members of your organization, they can benefit by reading the document, because it provides a detailed method on how to go about need assessment and analysis in nutrition and emergency. So don't just assume that this is a guideline for the nutrition cluster or sector coordination team. This is just a guideline for everyone who wants us to apply these methods in nutrition need analysis in emergency. So why did we do the revision, and what were the scope of the revision? So why we initiated this revision, there are a couple of reasons. One is there have been intersectoral guideline changes. And for those of you who are familiar with GIAF is Joint Intersectoral Analysis Framework, which is the analysis framework which guides the humanitarian need analysis or the HNO process. So there was a lesson learned and the subsequent development of GIAF 2.0 guideline. So it was necessary for us also to align the nutrition need assessment and guideline with this intersectoral guideline. And also the old guideline has some missing intersectoral overarching concepts, such as concepts related to risk assessment. So we wanted to incorporate also these important concepts in this guideline. And of course, as we work with you in a number of countries and several HNO, HRP exercises, we also drew some lesson from the application of the old guideline. We received your feedback. So it was necessary to incorporate the feedback and the lesson learned from the application of the old guideline. And of course, thirdly, the fourth point is within the nutrition emergency sector itself, there has been some technical advancements. For example, we came up with our nutrition community came up with new wasting pin estimation methods, which we will be discussing briefly in the subsequent sessions. And also IPC acute malnutrition analysis, they came up with a guideline for alternative data sources. So these are all important nutrition emergency technical developments that need to be included in the guideline. So in terms of the scope of revision, you may not see significant change in the structure of the guideline, the way it is presented. Mostly we kept it as it is, but we make sure that the content is aligned with the GF 2.0 or Interagency Standing Committee intersectoral guidelines. And we did some minor adjustment in the structure of the guideline. I will go over it later on. We created part 1 and part 2. And also we included the technical recommendations, which I just mentioned earlier. And also we introduced a new analysis process workflow, which I will show you later. And there have been minor changes in indicators. We haven't really touched much the indicators. There wasn't any major change with regard to the indicators used for need analysis. And also, we made some changes in the severity classification thresholds. There were new classification thresholds for some indicators, so we made that adjustment. And we didn't change the conceptual framework we use for nutrition need analysis, which is the UNICEF conceptual framework. So overall, what we can say is the scope of the revision focused mainly including the new nutrition emergency technical developments and aligning with the GF and intersectoral guidelines, and the structure remained more or less the same. Next slide. So now I will go one by one about the changes made in the guideline. And if any of the descriptions on the slide are confusing to you, please post your questions and comments at the chat box, and I will pause and respond to your questions or comments. So the first change we introduced in the guideline is aligning with the overarching interagency standing committee guidelines, which is mainly the risk-centric approach. And one recent publication by the UNDRR, which is the United Nations Agency for Disaster Risk Reduction, in collaboration with Interagency Standing Committee, they recommended any need assessment should have a risk-centric approach, meaning risk analysis is a function of hazard, vulnerability, exposure, and capacity. And also risk assessment shouldn't just focus on the current emergency. It should focus on pre-crisis, during crisis, and after crisis. So we took this concept and incorporated in the guidelines so that our assessments or need analysis takes into consideration the risk-centric concept and the risk-centric approach. So the main implication of this concept, which we drew from the Interagency Standing Committee, is one, our analysis as most of you know, is based on outcome indicators. For example, we usually look at GAM or SAM, and we classify the severity based on GAM and SAM status. But as most of you know, not every country has high GAM or high SAM rate, and some countries, in fact, have low acute malnutrition rate, but they still experience other nutrition-related risks. So the best way to approach the analysis is to focus on immediate, underlying, and basic factors. So there is also an option of classifying the severity or doing a severity analysis using other intermediary indicators, such as feeding practices. It could also be disease morbidity, and so on. So the risk-centric approach helps us to apply this concept for the nutrition need analysis. The other implication is, in most of the cases, our need analysis is mostly focusing on the current period or the point in time. There is less of projection. So if we apply the risk-centric approach, then in our need analysis, we will include projection. So this concept and this principle from the Interagency Standing Committee is very useful in making sure that our need analysis and assessment is consistent with the intersectoral practice. Next. The other change which we included is the concept of coordinated assessment, or the guideline related to coordinated assessment. Interagency Standing Committee has a detailed guideline which was published in 2012 and still valid. It outlines the types of coordinated assessments, assessment approach in various phases of emergency, and the role of the cluster coordination team and partners in the need assessment exercise. However, this aspect wasn't adequately reflected in our old guidelines, so we incorporated this part in the new guideline. Next. So just a quick exercise for you to test your level of understanding of coordinated assessment. You can write your response at the chat box. So the question is, what is the difference between harmonized assessment and joint assessments? Please also give examples of each, or one example for each. Have you heard of harmonized assessment and joint assessments? I hope most of you do. And what is the difference between the two? We take some 30 seconds. You can write at the chat box. I didn't see any response. Maybe not everyone is aware of this. You may try. You can also guess. What is harmonized assessment? Or what is joint assessment? Isaac, do you see any response?
No, we don't have any response yet.
Okay, perhaps maybe this is a new concept. So, okay, Hailu said, give us 1 minute. Hailu, 1 minute is granted, thank you. So we give you 1 minute. Okay, I think we can proceed. Isaac, next slide, please. I see Ashanafi's response. Harmonized is a common methodology. Balai. Okay, multiple sectors. Joint assessment is multiple sectors. Eugene, joint is doing it together. Harmonized means it separately, but mutual understanding. Very good. Somebody copy pasted answer. Okay. All right. So we can proceed. Thank you so much. Those of you who posted as a chat box, you correctly responded. So what we did is we made a distinction between the different types of coordinated assessment. As you know, the role of the cluster is not necessarily to directly implement the assessment. It is more of to coordinate assessment exercises. However, there has to be some distinction between the different types of coordinated assessment. So we do have two broad categories of assessments, harmonized and joint assessments. And in each of these cases, there is a role for the cluster and partners to play, and they have to understand what each type of assessment is and what sort of role and responsibility everyone should be responsible for. So this was added. There is nothing to go detail about it. You can refer to the guideline and understand more. And of course, you may want to refer to the intra-agency standing committee document, which really gives a detail about the detail of the various coordinated assessments. Next slide. Okay, the next aspect we included is what type of assessments should be conducted during the early stage of an emergency, onset of emergency. Usually 72 hours to 1 week is considered the phase 1 of emergency. And there are certain types of assessments which are recommended after 3 weeks or maybe more in most cases. So our guideline didn't have, our old guideline didn't have any distinction between what type of method should be used in what context, and also in terms of the phase of emergency, alignment with the phase of emergency. So again, another exercise, I give you 1 minute. What type of assessments are recommended within 72 hours to 1 week of onset of emergency? 2, what type of assessments are recommended after 3 weeks? After 3 weeks after the onset of emergency, sorry for the typo. I see some response at the chat box. Mustafa says, rapid assessments, 72 hours to 1 week. Min Zhao Yi, RNA or MIRA for 72 hours to 1 week. In-depth or sectoral assessment after 3 weeks. Balai, 1 rapid assessment, 2 situational assessment. Regina says RNA and MSNA respectively. Okay. Lawan, RNA for 72 hours to 1 week. Elena, RNA and MIRA for the first 72 hours to 1 week, and SMART after 3 weeks. Excellent response. I mean, you already responded very well. So in terms of phase of emergency, this is intra-agency guideline. So there are roughly 4 phases of emergency pre-crisis. Phase 1, initial stage of the crisis. Phase 2, the next phase of emergency. And of course, we have phase 3 and phase 4, which are after 3 weeks, 4 weeks, and beyond that. While this reflects for the rapid onset emergency, but the whole concept applies to some localized emergencies in a protracted emergency. So according to Interagency Standing Committee, we need to select the right methodology in alignment with the purpose of the assessment. The initial phase of emergency, the purpose of assessment is to get overall assessment, overall estimation of the people in need and the extent of damage or the extent of impact. It doesn't go in detail about the specific sectoral needs, which requires sector-specific methodologies, more in-depth household type of surveys. So, as you have responded as a chat box, this aspect of aligning assessment methodology with the timing and the phase of emergency wasn't reflected in our previous guideline. Now we have included this best practice from the Interagency Standing Committee in the GNC guideline. Again, you are highly encouraged to read both the Interagency Standing Committee document as well as our guideline. It gives you more detailed information about how to select the right methodology for the right phase of emergency. The other change on the intersectoral aspect is about the role and responsibility of cluster partners in need assessment and analysis. I'm not going to go in detail here, but I would like to emphasize the fact that in each phase of whether it is assessment or need analysis, whether it is HNO or rapid assessment or multisectoral assessment, the cluster coordination team and partners have a role to play. And we have to be mindful of that. And there is also a detailed guidance what the role of the partners and sector coordination team is in our need analysis guideline. So these aspects were missing in our past guideline. And in this revised version, you will see an outline of the list of role and responsibility of partners, as well as a cluster coordination team. Next. So now we go in detail about what specific change we made on the content of the need assessment and analysis process. So far, I only highlighted about some overarching intersectoral best practices and concepts that we included in the part 1 of the guideline. In this section, I will be taking you over the changes that were made in the practical step-by-step process of need assessment and analysis. So the first change we introduced is coordinated assessment planning and implementation. I will discuss more in detail about it in a minute. And also we included a 4-step process for conducting nutrition humanitarian need analysis. This is in alignment with the GF 2.0 process. And our past guideline, unfortunately, missed objective and output of the need analysis. It didn't show anywhere in the document. It doesn't indicate what the objective of the need assessment and need analysis should be and what are the expected output. This is very important because we have to keep in mind what we will get out of the need assessment or the analysis exercise. So we included a generic objective and a specific objective, as well as the output of humanitarian need analysis. And we also included a severity contextualization and severity threshold calibration. This is some guidance on how we make sure that we use context-specific indicators and how we calibrate their severity threshold. So we included that guidance as well in the document. And there was also a scope of analysis component included in GF. The scope of analysis is about differentiating between what is considered in emergency and what is not considered in emergency or humanitarian need. And there was an inclusion criteria included in the GF manual. We took that and we created our own nutrition-specific inclusion criteria for what we consider nutrition emergency need and what we consider non-nutrition emergency need. And by the way, this definition and inclusion criteria is already included in the intercluster GF technical manual, but also we are also included in our guideline. And of course, the other important point we included is the GNC definition of people in need. When we say people in need, what does it precisely mean, and what are the key considerations for considering people in certain affected area as nutritionally in need? And the other important change is wasting estimation options. In the past, we used to use a general incidence factor, which is 1.6 times the prevalence for estimating wasting people in need or wasting burden. Now we do have two additional options. We'll discuss about it later on. And of course, we made some adjustment on the GNC need analysis tool or calculator. And we added also a methodological note example that you can apply in your specific context. Next. So I'm going to go one by one of those, the list of changes that we introduced in this guideline. So I start with coordinated assessment. So the main change, and I would say very important change, is adding a coordinated assessment planning and implementation option. In the past, in most countries plan for either smart survey or maybe rapid smart survey. In some exceptional cases, they plan for rapid nutrition assessment. Other than that, the other options were not considered. And as we know, not every country has the technical capacity and the resources to conduct full smart survey. And in some cases, it may be necessary to consider other data source options. And we didn't have that guideline in the past. The good news is IPCA came up with this guideline, which gives options and various considerations for deciding which assessment to conduct in which context. So decision-making tool for using alternative data sources and methodologies included. And again, I highly encourage you to go to the document, the guideline, and refer to this section. So the implication of this is for you to consider not just full smart survey. I mean, of course, if you can, that's the best gold standard methodology. But if you can't, you can make use of other alternative data sources. So we provided this detailed guideline in the guideline. And again, you are most welcome to check the detail in the guideline. Next. Yeah, so the other important change is making sure that our guideline and process is aligned with the GF. Just briefly, the GF process has 3 modules or 3 important steps. One is analysis of the contributing factors, which is the main drivers of the humanitarian situation. This is done by, mostly led by OCHA, but other clusters also contribute to the analysis process. This is followed by the sectoral analysis, which is module 2, and followed by intersectoral peer review of the analysis, which we call it intersectoral needs analysis. So we, our previous guideline was produced before the current GF guideline, so it wasn't well aligned with the new GF process. So what we did was we made sure that the analysis process within our cluster is well aligned with the GF one, because we have to make sure that we start our analysis process following the initial analysis done at intersectoral level, and then we continue to the sectoral level analysis, and then we proceed to the peer review intersectoral analysis process. Next. I see some question. Before I move to this slide, let me address that question. Mustafa said, what about the surveillance? We can use it at all if the above not available. Surveillance is included in among the list of options, so you may consider the surveillance. But again, that decision should be made based on the quality of data assessment in your specific country. By the way, for all these alternative data sources, you cannot just simply use any data source, but you have to make your own assessment of whether or not the data quality is good enough. And then, of course, thanks to our nutrition assessment expertise, either from SMART Initiative, CDC, they have shared various tools to make sure that the quality of these non-standard assessment methodologies are maintained to some standard level. So surveillance is okay, but the quality assurance mechanism should be there. And Victor is something else. Okay. Okay, let me proceed. So the GF analysis, it has a platform. This is where you upload the nutrition sector analysis or you contribute to the intersectoral analysis. You can, again, refer to the GF guideline. There is a specific section which gives you the URL, the website of the analysis platform. For those of you who are cluster coordination team members, either IMOs or cluster coordinators, I hope you have access to this platform. In the platform, you upload your analysis, you contribute to intersectoral analysis. So what we did in our guideline, which I will show you in the next slide, is we made sure that the process, our workflow, is aligned with this analysis platform. So we came up with a 4-step process. Here you can see the 4 colors, the yellow, orangish, red, and green, and very light blue. So each step is aligned more or less with the GF process, especially step 1 is aligned with module 1. Step 2 and 3 are aligned with step 2 or module 2 of the GF. And of course, the fine one, the fourth one is aligned with intersectoral needs analysis, which is module 3 of the GF. So we made sure that our analysis process and analysis output is aligned with the GF process. This is important because our analysis should be contributing to the intersectoral analysis, and we should provide our input to the intersectoral analysis on a timely fashion. Next. Okay, this is just to show you how it looks like in a full screen. You can also find this in the guideline. Other major change is, as I mentioned earlier, we didn't have a generic goal and specific objective in our old guideline. We now included a generic need analysis and need assessment and analysis, objective and specific objective. So basically, the specific objective, at least a minimum, should consider analysis of the primary contextual drivers and contributing factors of malnutrition. It should also have an element of severity of the malnutrition and risk factors across different population groups. There has to be also a magnitude of the need, or in other words, people in need. And of course, we need to have a projection element in our analysis. I'm not sure we are doing this in all countries, in all contexts, but at least we do severity and pain estimation, but we are yet to improve when it comes to the contextual drivers analysis and of course the projection aspect. So we included these 4 important specific objectives of any need assessment and an analysis exercise and we have to apply this consistently, whether it is a small-scale localized need assessment and analysis, or if it is 𝗔𝗃𝗃𝗃𝗃, the same specific objectives can apply, but you can specifically contextualize to your context depending on what you are analyzing or what you are your need analysis focus, your need assessment focus is. Next. This is also another aspect added to the guideline. This is about making sure that every country has option of using their own context-specific indicators and severity threshold. So in the past, the practice has been there are some global standard indicators, and you use those indicators to end the threshold to do your need analysis. However, based on experience, we know that some countries, they may want to choose their own context-specific indicator, depending on their the data availability, and they can apply also severity threshold. However, they need to follow certain steps which we have included in the guideline. First and foremost, the severity threshold should be aligned with this generic definition of severity. I'm not sure whether it is visible to all of you, but you can still refer to this severity threshold calibration tool in the guideline. So what it says is severity 5 can be characterized in a certain way, which if the indicator shows a collapse of basic services. This is a very generic classification, but at least whatever you say is level 5 or phase 5 should be something which shows complete collapse of a certain service. And that service category or type can be dependent on each context. So this gives you flexibility in introducing context-specific indicator, and not only that, you can also calibrate the severity of that indicator. So it gives more flexibility in the analysis process. So, okay. And I see Bijoy saying, can you share examples of contextualizing indicator threshold calibration? I think this requires Bijoy one-on-one session where we look at a specific country or a specific context, we identify proposed indicators which will meet our analysis objectives. The analysis objectives are the ones which I already talked about. Then once we identify those indicators, which are context specific, we need to make sure that their severity, which you can classify their severity into a scale of 5, that's the standard practice, then you can describe what level 5 means for that indicator. So right now I can only say hypothetically, but this should be done on a case-by-case basis, and it should be done with the right people. This requires actually expert judgment. So I cannot give any specific examples. All I can say is this depends on the context, but we should follow the steps, the standard steps included in the guideline. But thanks for raising this point. Next slide, please. Okay, the other thing we added, rather we clarified, it was there in the old guideline, is scenario-based options for severity analysis. So we have 3 options for analyzing the severity of need, especially in the HNO context. Scenario 1, where global acute malnutrition is greater than 5%, and scenario 2, and we have IPC analysis data. Scenario 2 is where we have GAM greater than 5, and we may not have IPCMN analysis data. Scenario 3 is where GAM is less than 5, and sometimes also no global acute malnutrition data in a specific context. Now, look at the words that I highlighted in red in most parts of the country. So when we say a country has GAM greater than 5, it's very rare that the entire country is greater than 5. So the clarification we added is it should be based on this decision of classifying the country either to scenario 1 or scenario 2 should be based on assessment of whether or not most parts of the country are having greater than 5 or less than greater than 5 or less than 5. So this is a subjective judgment. Again, this is based on expert judgment. All we would like to emphasize here is that whatever classification you apply in your case, this refers to most parts of the country. It's very rare that the entire country has the same level of GAM. Some areas may have exceptionally low, and the rest of the country may have exceptionally or may have greater than 5 GAM. So here we are referring to most parts of the country. We don't mean the entire country. Koki posted something. Let me just take a look. Severity context would have already been used in contexts with GAM less. If scenarios in Syria, if I understand correctly, Koki, you are referring to application of alternative indicators where the context is less than 5. Yes, alternative data sources in most cases are, of course, they are applicable in all cases, especially in scenario 2 and 3, but it is very typical we apply them especially in scenario 3 contexts because one, there is less data availability. Secondly, we may not be using GAM analysis or wasting data for the analysis, so we may be using other data sources. So yes, I agree with your point. 𝗔𝘀𝗀𝗶𝗀𝗀𝗀 again, this GAM is by weight for height or, yeah, so this is, I guess, 𝗔𝘀𝗀𝗶𝗀𝗀 and assessment colleagues, I think I saw 𝗏𝗏 here. The standard way of measuring GAM is using weight for height Z-score. So yeah, in this case also we are referring as weight for height Z-score, but again, MUAC can apply because we are applying the alternative data sources, so we can use the MUAC based on weight for height as well as the MUAC GAM. Okay, next slide, please. The other thing we added is the scope of analysis or interagency standing committee or intersectoral PIN definition and PIN, the GNC PIN definition. So we have been discussing this in the last HNO exercises this year and also last year. The GF came up with some inclusion and exclusion criteria for PIN estimation or including people within PIN estimation or including or excluding from the humanitarian need. Accordingly, GNC came up with similar definition. Here you can see on the right-hand side that the GNC definition of people in need is as indicated. I'm not going to in detail of it, but all I'm saying is we have a clear definition of what needs to be included as humanitarian and what needs to be excluded. And of course, I have to emphasize there is exceptions. Exceptions, for example, OCHA or intercluster may say you can only include nutrition needs in areas designated as humanitarian emergency. How about in the contexts where there is no active conflict or any major humanitarian driver, but people are experiencing high level of acute malnutrition resulting from long-term development deficit, underdevelopment, or any long-term factors. Do we include or exclude them? Well, the answer is we need to include them if they meet certain criteria. The criteria is if the acute malnutrition rate is above emergency in that context. So all these are clearly indicated. There is more clarity on inclusion criteria for humanitarian needs for nutrition in alignment with the GF. Next. Okay, I see Bijoy comment about, unfortunately, we do not have severity threshold for CGAM. Yes, this continues to be a challenge, but the application of CGAM, as you rightly mentioned, is mostly for PIN estimation. We don't, so far we haven't used it for severity classification. So, very quick exercise again. What is the formula you use to calculate wasting PIN? SAM or MAM in your context. So this will be, I'll be discussing about the different options we have included in the guideline. But before we go there, I want to hear your experience on which method you applied in your most recent PIN estimation or case load estimation. Which one you used? Did you use context-specific incident factor, or did you use the generic, the global incident factor, which is 1.6 times prevalence, or any volunteer? Can you also write the formula as a chat box, which one you are using? Which formula you use to calculate the PIN for SAM or MAM? Okay. I see your response, Bijoy. Any others? Any other colleagues? What formula you used in your most recent people in need or burden or case load estimation of severe acute malnutrition or moderate acute malnutrition for your country, for your organization? Which one you used? Just to help you, the usual formula is we use prevalence plus incidence to make an estimate of burden or estimate for severe wasting or moderate wasting. And prevalence equals to incidence is equals to 1.6 times prevalence. So 2.6 times prevalence is the standard method we use. Do you apply any other method? Okay. I see Danka's response. Yes, prevalence plus incidence. Yes, I hope you mean incidence is equals to 1.6 times prevalence. This is annual incidence. Afghanistan, Koki said, we use combined GAM, 2.6 times combined GAM. So basically, they use the global standard incidence factor. Any other country, any other cluster who has most recent experience? And also, Koki, you mentioned you also considered admission. Yes, but in any case, let us look at what we included in the guideline. Next slide. So we added 3 options for estimating wasting PIN. Okay, Abu Bakr gave Nigerian example. So then in Nigeria specifically is incidence, context-specific incidence factor. So we have 3 options included in the guideline. 1, you use the global standard incidence. This has been the practice in the past and widely used. And some countries have context-specific incident factors. For example, Nigeria, they widely use context-specific incident factor. In fact, actually, every state has incidents, their own state-specific incidents, then they apply that. And thirdly, we have an estimate of PIN using coverage of wasting services. This is a new method, and this involves estimating the PIN using the prevailing coverage of treatment services. For example, if the coverage of treatment of some or now mostly some is very good, and there is a dependable data source, you can use the coverage to make an estimate of the upcoming year. So if you have a good data of coverage for this year, you can estimate for the next year. Of course, there are additional details, but this gives you an option of using your current coverage to estimate the upcoming year estimate of the wasting PIN. So anyway, these are the options included in the guideline. Again, as I said, you can refer to the guideline and get more in detail practical guidance on the steps for calculating the wasting PIN, and also Isaac will take us through the calculation tool, which we made changes on the formula, so he will show you later on. Next slide, please. Okay, let me address quickly Regina's question. Can the proxy coverage from smart be used to estimate the wasting PIN? As I said, the coverage should be from a standard source, which usually is a 𝗓𝗂𝗃 or a 𝗓𝗃. So which means we cannot use indirect or proxy coverage, right? So we should be using a coverage data from a dependable, methodologically robust method. So yeah, so this is a new approach. We will see how it will be applied in the countries. Okay, next slide, please. Yeah, so we made adjustment on the GNC need analysis calculation tool. So I hand it over this part to Isaac, and he will show you what changes we did in the spreadsheet, and also he will take you through how the revised calculation tool or analysis tool looks like. So Isaac, over to you. Before that, if anyone has any question or comment, I can take 1 or 2 minutes to address. If not, we go straight to Isaac. Isaac, over to you, please.
Okay. Thank you very much, Anthony. I hope everyone can hear me. So in terms of what Anthony has mentioned and clearly elaborated, now we will be getting into the Excel version of the GNC HNA tool, whereby in the worksheet, we have 2 pathways that have been created for calculating the people in need numbers for wasting, for HNO processes, for nutrition cluster. One of the worksheets covers the use of coverage of wasting services to calculate the PIN. And then another one uses the contextual specific incidence factor, whereby if a country has its known contextual specific indicators, we can be able to plug them in and be able to derive the specific PIN for that country. And then we have the normal one, where you use the global standard incidence factor. So additionally, in terms of the worksheet, we've added also another tool that helps also in calculating the supplies required for the people in need numbers or for any particular targeting criteria that is being used. Okay, now getting directly into the tool. The tool has close to 13 13 sheets, whereby it's a collection of tools, whereby we have areas that are looking at indicators. We have areas that are looking at the specific data sources, the analysis of severity, as well as worksheets which are incorporated to calculate the PIN. And additionally, as I mentioned, there's the supplies tool as well on it. So the first worksheet looks at the specific instructions, looking at the specific worksheets as well that have been incorporated inside the tool itself. The second worksheet covers the indicator registry, which here we are looking at key nutrition related indicators that have been adapted from the nutrition registry and framework, thus separating those considered to be core for nutritional situational analysis. And then the third worksheet is looking at the classification thresholds, which provides us a list of key core nutrition specific indicators, both specific and sensitive. So this will be able to assist in measuring as well the severity scales, as well as providing corresponding thresholds that are guiding the situational analysis process. The fourth worksheet looks at the evidence repository, whereby it provides the key summary of reliable scores that have been provided for as sources of evidence for the nutrition situation that is currently happening in country, which is adapted based on the IPC acute malnutrition reliability scale. And then we'll move to the analysis team composition worksheet, which is just a summary of all members that have been involved in the analysis process, and as well it's still adapted from the IPC acute malnutrition team composition matrix. The other worksheets will be jumping now into the scenario 2, where we'll be looking at the nutrition analysis. These provide the humanitarian situations where IPC acute malnutrition cannot be conducted, and prevalence of GAM for which children under 5 is greater than 5%. So the specific thresholds have been provided, and it's just updating it to provide the calculations for you. And then under scenario 2 for contributing factors, this is analyzing the contributing or contextual factors that are supposed to support the nutrition situation analysis, which has already been calculated through scenario 2 nutrition analysis. And this is often used when looking at the living standards pathway in the GF process. And then moving to scenario 3 nutrition analysis, where we are looking at the humanitarian situations where the prevalence of GAM for under 5 is less than 5%. This one provides additional information for analysis based on the situational analysis for nutrition. And then the scenario 3 contributing factors is just providing key contribution or contextual information that can support the nutrition situation analysis based on the information that has been provided. And then additionally, we have the population figures. This is looking at the current population that has been provided by OCHA for estimating the PIN in country, which has all key demographic information that is required for each of the affected population based on the definition of PIN that has already been incorporated in the analysis when conducting the GF process. And then we have the PIN wasting treatment, the 2 pathways for pathway 2, and then we'll see another worksheet for pathway 1. I'll be providing that more detailed information once I go through the worksheet, because those are the primary reasons why we have the webinar today. And then we have a worksheet where we are covering the people in need number and infant and young child feeding programs, where this is just providing the PIN number. And then we have another worksheet looking at the PIN for micronutrient deficiency. And then we have, I'll jump the last year population figure and pathway 1, because those ones I'll cover them individually each. And then we have key specific information under targeting per admin level that has been provided based on the calculations that have been computed. And then we have a sheet which provides a summary information of the key nutrition indicators, the populations which have also been disaggregated by disability context as well, that has been incorporated inside. And then additionally, the mentioned worksheet that I mentioned on supply, this is the additional worksheet that has also been incorporated. So starting off with pathway 2, I'll start with pathway 2, which is looking at the wasting and treatment. So this one, based on the information that is provided at country level and the population number, and already we know the situation in country, both the admission and treatment that has already been incorporated. The information is just fed inside the worksheet under the population figures. So the population numbers, remember, it's what now we've been provided for by OCHA to use in country. So here we have an example of a country where this information has already been provided. And then based on each level of information, you already know the population disaggregation figures. And then additionally, at the end, we have the key specific contextual indicators that have already been provided. So this one, either it can be the 𝗔𝘀𝘀𝗶𝘀 that we can have also, it's not the 𝗔𝘀𝘀𝗶𝘀, apologies for that. We can have either the option where we are using the global incidence factor to incorporate the calculation, but if you have country specific, it can also be inserted. And then once this information is populated, pathway 2 on wasting and treatment automatically calculates itself. The worksheet, once the population figures for the current year of planning have been incorporated and the key contextual indicators figures have been provided, it provides the full calculation across. So all this information is calculated automatically and it's not fed into the worksheet. So once you populate the population figures, the current population figures for the HNO exercise, and provide the key specific indicator figures, the incidence factors together with the other expected proportions based on the context in country, all these calculate to provide into pathway 2, where we are looking at the wasting and treatment numbers. So all this is provided and it calculates automatically by itself. Now, one of the additional worksheets that have been incorporated now under the new tool will be the last year population figures. Now, all these figures are provided based on what you had previously in the previous year. Now, if let's say you have both the current year's population and you have the previous year, you incorporate all of them. And then if you have additional information, now here is where, if let's say you have figures for last year under wasting, let me take, for example, the severe wasting treatment admissions for last year were 4,073. For this particular administrative unit, which let's say it's a district called Badakhshan. So in that district, we had last year severity wasting treatment admissions of 4,073. And then also last year, moderate wasting treatment admissions were 765. Now, once you provide this information inside the tool, and then additionally provide how the contextual indicators are for the previous year as well, when we go to pathway 1, under that particular specific district, we see that immediately we incorporate that figure there, it provides for you the PIN number and the specific disaggregation across the population groups. So this is done automatically and you don't need to incorporate it, but this is relevant for you to have the previous year's figures to incorporate. So the two pathways are close to being similar, but now this one for pathway 1 incorporates both the current year and the new year, whereby the population numbers, if in case you have any particular adjustments, it calculates itself automatically and it feeds directly into the tool for you to have the specific numbers. And then additionally, once you populate for all the specific districts, if we go to the PIN total, it gives you a summary overview in terms of the specific numbers based on the key indicators that we are currently incorporating for our calculation in the current year. Now, let's say we have this, the PIN total, and we want to know the supply requirements as well, based on the information that has been provided. This can also be calculated by the tool now, based on the worksheet that we've incorporated inside the sheet, which also calculates for you. But it's key to note that the relevant unit cost values that have been provided are based on standard UNICEF values, but it can be contextualized to adopt based on the situation in country and based on the requirements that each partner might be using, and you incorporate the specific figures. So the dollar value is editable and it can be incorporated based on the situation. The quantities, the total values, all those ones come automatically based on the calculations that have been provided in the PIN total. And then the target value also might need to be incorporated because country and context by context. In some countries, we have situations where there is full adoptability of the PIN, but in some countries, the target value might be less than PIN. But there is no scenario where the target number is higher than the PIN, but it might be case by case basis that this situation happens, but it's addressable based on what is agreed and consensus in country. So I think that is all from my end. Any questions?
Thanks, Isaac. Thanks for the demo and for the clarification. I see Geraldine's comment. Let me read it. For population figures understood, we put some and admission of previous, but for the population data, we still use current. Yeah, of course. Yeah, I mean, population data is the current year, the most updated population figure. That's the figure we use for all PIN estimations. So population figure should be the current one, updated one, usually shared by OCHA. So we use that figure. So yeah, correct.
Correct. Yeah.
Okay, so Koki has raised her hand.
Yes.
So Koki, go ahead, please. Can you unmute here?
Yes, just a bit. Yeah. Please unmute Koki and speak.
Yes, thank you, Isaac. Thank you, Antenna. There are instances where when agencies, using their own analysis, might have an opinion of the population proportions. So going beyond what OCHA has provided, and maybe at the country level, we are not able to, contextualize this probably using the SMART survey. So when the agencies provide this, their opinion on the proportion, whether it's under 5 or it's PLWs, what can we do? What data set should we rely on? Because as a cluster, we tended to push back, especially if it's not coming from standard survey like the SMART surveys.
Mm-hmm. You mean the proportion of population, like the age groups, or which one?
Yes. Yeah, the demographic, like for the, one that we had a discussion on was on PLWs, which it wasn't very clear, but the agency, of course, has used their own methodology. But on the contrary, from the SMART survey, we do not have that information. So what are we supposed to use? Is it the opinion of the agency that are advising, or you just go by OCHA?
It should be intersectoral decision, because all the clusters, all the sectors should be using the same population estimate. I mean, the same population estimate for that year. So admin X should have one estimate. It shouldn't vary by cluster. It shouldn't vary by agency. So that's actually a must. It's not really optional, because otherwise we end up having different estimated using different population figures. So yes, 100% it should be OCHA or intra-agency provided population figure, and agencies cannot use their own population proportion or population estimate figure. Yeah, I hope that that's very clear.
Thank you.
Okay. Is there any other comment?
Yes,
no, the population, the proportion of population figure, the proportion of under 5 children should come from the leading agencies, usually UNFPA or any government agency, the National Statistics Authority, in coordination with OCHA, with the consensus, with the cluster, the clusters, they come up with the population proportion as well as the total estimation of population per administrative regions in that particular point in time or in that particular year. This applies to also the number of IDPs, people on the move, and so on. There has to be some discussion intersectoral to agree on a commonly used population figure. So this is the standard way it should be done, and we should continue to do so. Yeah. Okay, so unless there are any additional comments, let me move to the last one slide, which is about methodological note. Thank you, Isaac, for very clear take us through for taking us through the tool. Okay, the last one is everything we do in the analysis process need to be captured in a very brief note, which explains the steps we followed, the data sources we used, the analysis process followed, and so on. That we call it methodological note. And some countries already submit methodological note to intersectoral mechanism or to OCHA for every HNO exercise they do. This is an example from Ethiopia, which was used in 2022. They clearly outlined what data they used, how they came up with the analysis, who participated in the analysis process, and how their estimate compares to the previous year. Basically, it captures all the frequently asked questions on the analysis. So this basically justifies how the analysis is done. And so we included this example as a template for other countries to use. And of course, several other countries are using this methodological note. And now is going to be a compulsory exercise with the need analysis. So we also highly encourage you to take a look at this example, and you can create your own context-specific methodological note template, so that you submit your analysis with some explanation on the process you followed. So that's the last section on the revisions made. Just to give a final summary of what we covered today, we started on what this guideline is all about. We talked about briefly what are the reasons we initiated this revision exercise and the scope of the revision. And then we went in detail about the specific changes introduced in the guideline. Again, we encourage you to look at the guideline. I have already shared the link, and you please feel welcome and access the document. You are free to disseminate it and use it. And of course, as usual, if you have any question, please reach out to us. We are available to support you during HNO or anytime throughout the year as usual. So unless, Isaac, unless you have any final thoughts, any comment or point, I think we can finish the webinar.
Yeah, I fully agree with you, Anthony. So after this, we will have the PPT and recording being shared either by the end of this week or early next week, together with the recording. So this will all be uploaded as well on the GNC website as well. Over to you, Anthony.
Thank you so much, and thanks everyone. Unless anyone has any final comment, we can end the webinar. And thank you for joining. And yeah, enjoy the rest of the day. Thank you so much. Bye-bye.
Bye-bye, everyone. Thank you.